Now we've added a potential long-term complication when you're looking at what, a 10 to 15% chance of getting an incisional hernia from a standard laparotomy. So that other 85, 90% probably never needed that piece of mesh in there.
Right, so it's all about intent to treat and the numbers required. And if there's a 1% incidence of chronic mesh infection, you got to treat a lot of patients to prevent those hernias. And I always throw the number around 20% incisional hernia rate, but regardless of who you read and what you believe, it's a real number. But that means 80% of people aren't going to develop that incisional hernia. So you're going to use that in every patient? Do we just identify the patients who are at highest risk? I think that's a challenging conversation to have.
And I think the other thing, at least historically, it's been insurance doesn't pay for it. So it's one of those things, if insurance is going to cover the additional cost, is it something that's going to be able to be implemented in every hospital system, even if you did want to go down that pathway? Because as we already talked about, CPT codes, money matters in this world.
It does. Now there is a Category 3 CPT code for mesh prophylaxis, 0473T, that can be utilized. That code often is not reimbursed. The cost of the mesh material is usually bundled into a DRG or an outpatient facility payment. So for most patients, that's not going to be captured. Occasionally we'll have payers provide some additional reimbursement for the use of that code, but you're right, by and large, it's something that we're doing for the good of society, the good of the patient, but at a financial loss.